It is now my distinct honor and pleasure to introduce one of our keynote speakers, Dr. Martin Elliot. He's had an impressive 39-year career in pediatric cardiothoracic surgery, and he's contributed heaps to our field, including pioneering surgical techniques. He's here to speak to us today about his work reforming pediatric cardiac services in the UK, remodeling the system to get the best outcomes for the lowest cost. Please join me in welcoming him.
Thank you very much. It's a real and genuine honor to be invited to speak at this meeting. A real pleasure. I've met some old friends and made some new ones. I have no disclosures, but I'm so old now I haven't got any. Except to say that there's a very nice lady in the beginning of the exhibition who took one look at me as I was going in there this morning and tried to get rid of the bags under my eyes, which was slightly depressing. So this is a talk which is about a system, a single health system. I'm going to talk about the UK. And I need to start off with a bit of history to give you a reason why we set about building a regionalized system. And the history, this is Gresham College, where I'm now the Provost, in 1597, as it was then. I wish it looked like that now. It doesn't. But regionalisation of services is an extremely difficult thing to do. And the history that I'm going to tell you about is local, and there are quite a few people here from Bristol, but this goes back a bit. Many of you weren't even born when this story was beginning to happen. But in the 1980s and 90s in Bristol, there were a series of excessive deaths and complications in children undergoing repair of congenital heart disease. These are some of the bereaved parents at the time. Now, it's a story about England, but it can happen in any country. This was in 2019 in the US. Individual centers not doing well and being exposed in the media for reasons which are often quite obtuse and difficult to identify. So, this was the situation in 1970 in England. We had all these centres. I think it adds up to 16. And Bristol is in the southwest, 2 red dots on the southwest. In 1975, James Wishart was appointed as a cardiac surgeon with a plan roughly to start on pediatrics at that time. And there was a huge amount of money chucked at the problem because in the 1970s, Bristol had the lowest amount of funding from the government of any place in the UK. And it became a designated pediatric centre in 1984. A new surgeon was appointed in 1985, Janardhan Dasmana, and they moved from 100 cases a year to 435 cases a year during that era. Janardhan rapidly increased the amount of pediatrics that was done in the centre. And in common with the rest of the profession around the world, there was a move from doing the Senning procedure to the arterial switch, and this move from older children to neonates was happening really during the 80s all over the world at different rates. And the best results were coming in the best centers, which had the best facilities. But there was huge pressure from parents and from cardiologists for everybody to do it. And a lot of pressure was put on Bristol to do it, and Janardhan particularly, and they had to aim for what was then the going rate of about less than 10% mortality. They appointed a new anaesthetist, Steve Bolson, who started at the same time. And Bolson, who'd come from a busy centre in London, noticed immediately that the operations in Bristol were just taking much longer than he was used to. And he started to get suspicious about what was going on. And not surprisingly, because Dasmana carried out 38 arterial switches, 20 of whom died. That was a 53% mortality. James Wishart had been promoted, and he was now Assistant Director of Cardiac Surgery. And Bolson continued to audit the results secretly, very bizarrely in a way. He did this secretly. And in 1994, more results came under scrutiny because he'd observed and reported that the repair of atrioventricular septal defects done by James Wishart had a 60% mortality. 9 out of 15 had died. Again, there was this movement from doing them older into within a couple of months of birth. And in 1991, they realized these results weren't very good, so they approached me to come and be a surgeon there and to lead the academic program. And when I looked at the job, it had all sorts of problems. So the surgery was done, pediatric surgery was done in the adult center, the Bristol Royal Infirmary, where all the kids, the cardiologists, and the specialist pediatric care was somewhere else in the children's hospital. And there was a third place where a lot of echocardiography lived. So trying to integrate this was a mess. And there was a flow diagram, which I'm not going to read the details of, but trying to get a baby well looked after in this setting was awful. And I said no to the job, pretty well, one of my better decisions. And I wrote a letter which came back to haunt me. And this is what I wrote to them after I turned it down. And the key words are, I think the whole thing's potentially dangerous. Right, which wasn't rocket science because the results were awful anyway, so it was fairly clear. Bolson's audit leaked, and it leaked into the national newspapers via a satirical magazine called Private Eye, and the headlines were amazing. They called the operating room the killing fields, and the intensive care unit the departure lounge. I love the wit, but what this must be like if your child is going in for surgery in a place like that must be a horrible feeling. So Steve Bolson then tells the government, the Department of Health, another local hospital medical director says, this can't go on, and told the Royal College of Surgeons and said, sort it out. Janardhan Dasmona stopped doing switches, and the heads of department suddenly got shown his previously secret audit. And the Royal College of Surgeons were called in and unbelievably gave them a positive report on the basis that, well, they'll get better if they do more cases. I mean, it's quite interesting how cultural things change over time. Bolson's audit, he said he showed it, gave it to a government official in detail, but he said that official apparently never actually read it. So the data were disappearing into some sump that nobody saw. And then little Joshua Loveday turned up in 1995 needing, I can't remember the details now, but needing a complex arterial switch. And this is where it gets interesting. So the cardiologists who were desperate to become a recognized small baby center said, you've got to do this child switch. Everybody else thought he should send it somewhere else. He was put under a lot of pressure and he did operate, even though the government said, not on your life, don't do this. And guess what? Poor Joshua died on the operating table. Now, the parents of children being cared for in Bristol were already organizing themselves into something called the Bristol Heart Babies Action Group to say, get on with it, change something. This is simply not good enough. So the families were doing something to change it. They called in a cardiologist from Newcastle and my colleague Mark de Laval to inspect the unit. And they said, crap data, can't make anything of this. The organization is rubbish. And the unit needs to be reorganized and strengthened with new appointments. Well, that's now 4 years after I had a look at the job, and basically nothing had changed. Wishart stopped operating and resigned as medical director of the hospital because this exposure of theoretically his performance was very damaging to him mentally. It was awful. There was a lot of publicity, a television program called Panorama, which went out every week and for an hour long. You can still see this on YouTube. It's really distressing. And Steve Bolson resigned from the National Health Service and went to Australia, where he now lives and is a professor of anesthesia. Looks awfully like Florida, actually, doesn't it? The General Medical Council, which gives doctors their license to work, organized an investigation, and that investigation coincided with Wishart retiring, and then they had a formal hearing of all of these cases associated with mortality. The terms of reference are complicated, and I haven't got time to show them. It doesn't really matter. But the hearing, 1998, was an awful thing. I was an expert witness and a defense witness, and I'll explain about the defense witness as well. I was an expert witness because I'd said it's potentially dangerous in my letter. And it was very stressful. Lots of little coffins, all the parents outside. It was really difficult to enter. The data that that group of people were working on were rubbish. They came from nationally collected data, which we were paying for ourselves to have collected, but it was poor quality, it wasn't complete, there was no risk stratification, and it was only based on the procedure done. Essentially, what it showed rather badly was that Bristol was not improving while other centres were. The outcome of the hearing was that Janardhan Dasmana on the right, James Wishart on the left, and the medical director in the middle were all struck off the medical register or suspended for long periods of time. They could not practice as doctors. Frank Dobson was the Minister of Health, and he said, oh, well, it's great having a GMC query, but we need a public inquiry to sort this out. GMC issued a lot of guidelines, which were quite good, and the lawyers got busy and made a lot of money, unsurprisingly, out of a terrible series of outcomes, and deservedly, they looked after those cases. Now, one of the problems, which I'm sure we've all encountered, is that countries are run by politicians. And politicians don't always understand things. And certainly their knowledge of statistics is dubious. And this is one of my favorite quotes of the period. And I won't read it out because I just want you to read it for yourselves and come to an appropriate conclusion. It's so wonderful. That was the Minister of Health that said that. You know, it is impossible to believe that someone could look at those data and make that conclusion. Robert Francis was the defending lawyer at the trial, at the GMC hearing. And he said, I'm going to emigrate. This is absolutely terrible. They have basically fried James Wishart alive. He said it's the apotheosis of the blame culture. Someone had to be seen to pay. The surgeons were blamed, but nobody else was called. No cardiologists, no non-medical management, no board of the hospital, no strategic planners for the health service, none of them. And the reason was they couldn't afford or enough time or money to bring in that level of evidence. They were happy to close it down. Then there was a full-scale televised public inquiry. It cost £15 million, which was quite a lot of time then. And Sir Ian Kennedy, also a very good, wonderful medical lawyer, did it and made a lot of statements, 150 detailed recommendations, which I'm not going to list, you'll be glad to hear. But amongst them was this: there are too many cardiac surgery units in the UK, and really difficult stuff should be just done in a place where people are good at doing really difficult stuff. And there should be a defined minimum number of procedures that institutions, surgeons particularly, should do. And the fact that we had been worried about people being able to make it easy to go to the hospital, he said, shouldn't matter. They should go wherever the good care is. And he said Jim Monroe, who sadly died as a cardiac surgeon from Southampton, set him off with this question: what's the right size? And he concluded, after visiting every centre in the country, that no unit should do less than 300 relevant operations a year. And if that had been followed at the time, half the units in the country would have had to close. And politically, especially when nobody knows what the average is, that was going to be quite a challenge. Now, surprisingly, we were all anxious to make a change. We didn't want there to be another Bristol. Everybody wanted to get better. And so there was a move to make us better. Roger Boyle was a cardiologist, head of the Royal College of Cardiologists at the time. Sheila was the head of the Royal College of Pediatrics. And they chaired for us a consensus meeting with all of the units in one room like this being represented. All agreed that the number of units should fall to 7. 7 units for the whole country. All recognized that their own unit might be a victim. In other words, could be closed and people would have to move house and school and families and everything. And all agreed and signed up for the change. And the change was a big document. It wasn't just nothing. Then Sir Bruce Keogh, who was also a cardiac surgeon, ironically used to be my registrar. It really pisses me off that my registrar got a knighthood. How did that happen? Anyway, he was a very good medical director, and he set off something called a Safe and Sustainable Review, yet another review. And he said, if we don't get this right, it's going to be a stain on our soul as a profession and a government if we don't sort this out. 31 surgeons, of which 10 were purely pediatric, in 11 centers doing 2,300 cases a year. Some centers were doing less than 100 and only had 2 surgeons. So if someone got ill or they had a family problem, they couldn't cover it. Now he was very exercised by, not by golf, but by the principle that the more you do, the better you get. And I personally believe that's true. All my life, the more I've done, the better I've got at something, except for my backhand, which is still rubbish. But for Gary Player, the more I practice, the luckier I get. It's a classic quote, but it's really true. Now, trying to actually physically reorganize a country is not a piece of cake. And the governance of the NHS changes pretty well every decade, and often with a level of complexity that you couldn't imagine. And this was the state of play at that time. Now, I'm not going to read the detail, just it's complex, right? On the left, the oversight and scrutiny committees, and on the right, these judicial reviews are things that will crop up again a bit later in this talk. So just know that they exist. The point I'm trying to make is that it is really complex, and that's all you need to remember. But the government, the Secretary of State, the boss of the health system, had some rules if you wanted to change anything. They're listed here. And you need a lot of support, strong evidence that it's a good idea, and everybody in the public engaged in the change. Right, sounds easy, doesn't it? Well, so they launched a public consultation, which cost £6 million, had 75,000 detailed responses, took 4 months. A lot of it was in public, and we had I had to attend with many others, a lot of people in town hall meetings. So the one I remember vividly is going to Leeds, where to talk about the fact that Leeds might close. And we had to be escorted off the stage by armed guards. And they had a really interesting question from the audience. This is a bit of a digression, but some lady stood up and said, my child has had the most wonderful care at Leeds, and how dare you close it? So one of my cardiology friends on stage said, well, if you don't mind telling us all here, what was wrong with your child? He said, had an atrioventricular septal defect, an AV canal. And he said, well, when was the child's operated on? Oh, it was 2 months. And what happened? Well, after a month, it needed a mitral, a left-sided valve replacement. And they didn't want to do that here, so we raised some money and sent it to Toronto to have it done. I came back from Toronto and had been in the intensive care unit for nearly a year. And the care was wonderful from the nurses, but the care medically was bizarre. So we were sitting out there facing this audience trying to say, well, we don't really understand each other here. We're going to have to think again. And that's when the armed guards needed to rescue us. We don't have guns in England, by the way. It's quite unusual. The decision about what to do, should we close these units, was taken in public on television in 2012 against a detailed business case. Leeds, Leicester, Oxford, and the Royal Brompton in London, all quite famous institutions, were closing. That took us down to the 7 centers. And everybody, all the royal colleges agreed. So it's like it's got everything that's necessary to make the move. Except, unsurprisingly, those units fought back. And they did it using that process of judicial review, which can only address, was the process fair? So they went to the judicial review. The Brompton lost. The NHS had to pay the bill, £2 million. Leeds won, but only on a legal technicality. Otherwise, everybody thought it was the right decision. But the oversight and scrutiny committees are entirely local. The local MPs and some local councillors said, well, this is awful. We're going to have to appeal to the Secretary of State, who was Jeremy Hunt, who is now our Chancellor. And he ordered something which he had in his power called a reconfiguration panel. It gets more complicated. And that was chaired by yet another surgeon, a general surgeon, called Ribeiro, who was president of the Royal College of Surgeons, very lovely man, well established. But the IRP had only experts in reconfiguration, managers, people who worked out whether we had spoken to the right people, and no experts from the specialty. It took 5 months, and at the end of it, they said we'd done a really bad job because we hadn't consulted properly, and therefore they suspended the review completely. That was 12 years after Kennedy had his inquiry, and Kennedy had said at the time, we need to get on with this. Right, so we have a country, a population, all the profession wanting to make the change, and we're stopped by complex bureaucracy and legal processes. So they ordered a new review. Good luck with that. Same cost, essentially the same outcome. The Brompton and Oxford now were to close. Leeds stayed open. But what it was based on was subtly different from what we'd said before. Because time had moved on, we were trying to make a different approach. And the approach we adopted was to make mandatory standards for a center that wanted to do pediatric cardiac surgery, any center, and the formation of detailed networks. The standards that we wrote are still available to see on the internet. It is a fantastic book. If you do those things, even now, several years later, you probably would build quite a good unit. It was quite an extensive document, but it was written jointly with the professionals and the parents groups and ended up with patients pretty well getting what they wanted. And to be designated, a center had to meet the standards. They were given a bit of time to correct things that they couldn't do, but they had to meet it. But we underestimated some important cultural issues. Firstly, relates to these two beautiful people here. There's a very good general surgeon in Seattle called David Flum, who wrote a wonderful paper in 2014, where he looked at why people go to individual hospitals and observed in his findings that patients drive past a hospital with the best results to get to a doctor who smiles. And that reminded me of, in London anyway, of the 3 A's rule of private practice. May not be relevant here because people are allowed to do private practice all the time or not. But in England, you have to do a bit and you set yourself up in a street somewhere called Harley Street. And you need to have the 3 A's: availability, affability, and ability, but in that order. Right? You do well in private practice, it often doesn't matter how good you are, as long as the first 2 are in good position. That, going to the doctor who smiles is kind of reflective of that. Patients and families did not want to travel to the best unit. It's really interesting, isn't it? What they expected us to do, and this was the cultural gap, was it said, hang on a minute, don't make me drive from X or to Y. Your job, you group of people out here, is to give us the best care everywhere. Why can't you get on with it? It's a really good question. Anyway, so Britain is quite small. There you are, to scale. It probably, I couldn't work out how to bend the boundaries, but it probably would fit into Texas. And England by this stage had a number of cardiac centres, and I'm just going to highlight Newcastle and Leeds. The distance between them is 98 miles. But culturally, they're about as far apart as Fargo and Fort Myers. Right? They have quite a significant difference in culture. The people in Newcastle speak a slightly weird language and didn't want to go to Leeds because they were Yorkshiremen, and the Yorkshiremen would never go that far north because the beer tastes different. So you had a very, very structural, emotional disconnect between what they wanted to do. And we hadn't read the room very well. We thought Leeds at the time didn't have very good results, Newcastle had better results, and it had a transplant centre, so why wouldn't you go there? It's 98 miles, it's commuting distance in Los Angeles. What's wrong with you? Anyway, they were right and we were wrong. Because regionalisation, as we've come to do it by setting these standards, really means networks. You sort of hinted at it when we were hearing about Maine just recently. But this is what the diagram kind of looks like, and I have to shortcut a huge amount of work. But a network is set up with a lead provider, for example, Great Ormond Street. It's a managed service with a leader, and it works against an annually revised business plan. Right, so it's properly funded and managed. And it has certain components: a surgical and pediatric cardiac surgical center, an adult congenital center, cardiology, and all that goes with that in one place, including all the interventional radiology and the cath labs, and the MRI scanners. Then there are peripheral pediatricians with expertise in cardiology, not necessarily pediatric cardiologists, but sort of half-trained pediatric cardiologists who are also full-blown pediatricians. Clinical nurse specialists who are very trained by the center to manage children with congenital heart disease, and they're dispatched to nicer places to live than central London, with fields and trees, things like that. And they have they're very, very much important to managing the flow of patients. The principle was to devolve as much care to the periphery as possible. And nowadays, it's quite reasonable to drive the MRI scanner and program it from a keypad in London for somebody having an MRI scanner remotely. It's not, things are changing so fast. But the protocols, the communications, the audit, the data management are uniform across the platform. And at the center, 4 surgeons doing more than 125 cases each per year. Pediatric cases, not adults. So is this system effective? Well, obviously you have to monitor performance, and you just have to be in a room like this to realize that a Norwood isn't the same as an ASD and so on. There are big structural differences. A case is not a case. And so you need something which risk stratifies the performance, because you've seen it as well with the STS registry, where people say, oh, well, I'm not doing I'm going somewhere else because we don't want to worsen our results, so send all the difficult stuff somewhere else. So it's really important to find a way of doing that. And UCL, University College London, had an operational mathematics department run by Martin Utley at the time and Christina Pargel, who's the new professor. And they worked with Great Ormond Street to develop PRAISE, which, has anybody, who's heard of this, by the way, in the audience? One person? One person, it's very good. You've got no excuse though. This is a really important thing because it can actually theoretically be applied in a number of settings. So I'll try and explain it without getting into the core maths. But the basic principle is a bit like snakes and ladders. If you do a high-risk operation, such as, let's say, a complex Norwood, then you go up a little bit, or you go up quite a long way. If you do an easy operation like an ASD, you don't go up so much, just a little bit. If a patient having a high-risk death dies, you drop a certain amount, but not as much as if a low-risk patient dies. So you end up getting zigzag lines like this, and the vertical axis on the left is expected versus actual over a 3-year period, with the 0 point being the national average, above which some people exist and below which is a disaster, of course, according to the Secretary of State for Health. Anyway, you see, that's Great Ormond Street in, I think this was 2012, 2013. There were 9 deaths in the whole year. They were all complicated cases. And the overall performance was much better than the national average. So you could rub your hands and say, we're doing okay. I mean, that's all you can say. It's not bad. If you're going in that direction, you need to do something about it. I just want to re-emphasize what we've heard, I think, in almost every talk. The health now is a digital health economy. Data are what we do. There isn't anything that we do in pediatric cardiology which isn't managed in a digital way. From the MRI, the echo, your machines. The data stream is growing extremely fast. But when you're looking at the results of units, there are some things which I think are rules. And you can argue with me if you like, but I think collecting the data should be compulsory. There should be no defense from a unit not submitting data. In fact, you should lose your license, I think. The data collected should be complete. So that is, all that is necessary to go into the national reporting should be complete. It should be confirmed. In other words, you have to have an audit. And that audit I'll just explain in a minute. But the core of it is that your peers and your industrial supervisors, the managers, come in and check that it's all right. It's no longer owned by the surgeons, which is a really important thing. Surgeons actually tell lies quite often, I'm sorry to tell you. And they have very, very large egos. So they're always going to want their results to be visibly better than everybody else's. I think transparency is the key to the success that's happened. So these data should be made visible to the public, not to our units. That's okay. We all know pretty intuitively who's good and who's bad, but the public need to know because they've got to make some choices. So this email address, website on the address is live. I'm not going to go to it now, but you can go to it if you want to, childrensheartsurgery.info. It's up to date, and it shows the results of cardiac surgery in the UK based on these things. I'm going to show you a little bit of it. These are the current centres. You'll see there are 10 of them because Dublin is included. We didn't close as many as we thought we would close, which when you show you the results, quite interesting. You'll see that there's a sort of slider up here on the top, which allows you to change the precision of the view. And that all of the cardiac units in the country, all of them, have results in the 98, 99% survival. All cases. If you broaden that sensitivity, make it 100% wide, you can see you have 95 and 98% confidence intervals in dark and light blue. And the black dot indicates your results for your center in the preceding 3 years. And this is available to the public. And when you click on the center, you also go much deeper into individual conditions. The risk stratification model works deeply in several dimensions. So if I zoom in on Great Ormond Street, because I should, that's where I worked, you'll see that this is how it's explained to the public. And the way this is presented and the way that's explained was the product of nearly 2 years working with the public to find out how they wanted to see the complexity of risk stratification. And they wanted to see it in this level of detail, not much more, but they wanted to be able to click on those names and go further into detail if they could. So the headline here is, as it says, did a lot of operations. 9 people died during that time. The 30-day survival is 99.4%, and that's better than expected against the model, right? But if you remember, there was no statistical difference between any of the centres, none in the UK. So out of those 10 centres, they were not differentiatable, except that Great Ormond Street did slightly better than predicted. Could be different next time. But I would be confident that it was safe to go there. Nobody jumps higher by lowering the bar. So from what you've just seen, is mortality a reasonable indicator of performance of a centre? How would you differentiate Bristol from Great Ormond Street? You can't. They're not statistically different in the way it's being presented. So we need to move on and find a more sensitive outcome measure to improve our comparison. But we've got the structure now, a working structure to play with the comparison between centres and drive quality upwards. And Kate Brown from Great Ormond Street is driving a program looking at complications. I should say, when I was medical director of Great Ormond Street, the 11% of patients in the hospital who had complications cost us 50% of the overall budget. Right? So complications equals money. Complications going down is good for families. Complications going down says you're doing a decent job. It's quite a good place to start. And Kate has been looking with 5 other centres in the UK at this long list of things. And I'll make it work. Over 3,000 consecutive operations. If you had a complication, you had a much less good 6-month survival than if you didn't have a complication. Straightforward, simple piece of maths, but fantastic for a family looking at it. They want to know, is it safe? One of the worst things you could have is neurological damage. And again, not going to go into detail because it's the principle that counts. We're not just reporting death now, we're reporting other things. Neurological damage has a wide range from 2.5% to 0.4%. That's quite a big range. So the centres at 2.4% would save a lot of money and get better outcomes, almost certainly, if they could bring that down. And so there's, more work gets done to look at that. And do you remember that I talked about the surgeon getting blamed? And in the States particularly, that very often centres with a relatively small volume, if they get bad results, what do? They swap the surgeon out. They hire a new surgeon, fire the surgeon. And this is getting really hard to adjust because more and more, especially in complex cases, 2 surgeons, 2 attendings are operating together. So who is the surgeon? And that really matters about reporting, whether you report the institution or the surgeon when you're doing a comparison. So I'm winding up, and I want to tell you what I think we have learned from that awful experience of Bristol. Number 1, everyone agrees that you should alter the number of centres in a place until it becomes existential. In other words, your centre is the one that's going to close. And they can say, we're really happy about the closure of it until they've got to move their kids from school. And then they get quite upset. But team reporting of results externally and surgeon reporting internally, so we've got real detail about every individual surgeon, but we just don't tell the world about it, but you can find out. But internally, it matters so that we can organize, as you'll hear tomorrow, retraining. Clinicians and parents group don't always know what the population wants. That was our discovery about traveling past to find a doctor who smiles. I can feel confident that the national standards, regionalisation and large volumes work. We have generated remarkably consistent results in a whole country. And if you have out-of-range performance, what happens is that your peers, a member of the government and a member of the Royal Colleges come to your institution and say, well, you've slipped below the 95 confidence interval. Let's look at your data and see what that shows. If you're below the 98th confidence intervals, we stop you operating for a bit, nobody gets fired. We dig into the data and retrain if necessary. Surgeon, perfusionist, whoever it is that's not actually doing a good job, gets retrained to do a good job because they all can, they all care. This is national service, national data, and national performance monitoring. It's compulsory and it's transparent. The standards-based approach, making these networks apply the same rules everywhere, has been more effective than we expected. Somebody in the middle of the Bristol inquiry said mediocrity must not be the benchmark for our future. I would argue that regional networks do work if they're done properly. And that's not to be forgotten. Nobody is paying for any of this treatment. And by the way, surgeons, perfusionists, everybody working in the health service, there is no gender difference. We don't have to negotiate a pay rise. We are essentially unionized, but everybody gets the same. So I get the same as a dermatologist, and I got the same when I was running the hospital as I did when I was running as a cardiac surgeon. There was no bonus for any of this stuff. The system is built on people wanting to deliver a good service. I want to leave you with one slide. You are all here to talk about a small part of a child's life, the operation. Right, but surgery is only an event or several events if you have lots of operations in the course of a disease. There are many, many other things which influence outcome. The genotype, as you know, anybody who's worked in Philadelphia will recognize, is of key importance to long-term survival and quality of life. But what happens in interventional radiology and what drugs they take, what their lifestyle is, and specifically all over the world, your financial status will influence your long-term life chances more than what you do in a bypass and more than what I do in the cardiac surgery. We must never forget that the lifetime results should be followed, and this should be diagnosis and not procedure-based, because the procedures that we do will change over time. So the variable should not be the operation, that should be the variable, not the key indicator. It's quite a lot of complex maths to come, and the AI is going to make that easier, but not cure it. I'm going to stop there and say thank you and advertise. I'd like you to all to go and visit this fantastic website or our YouTube channel, which is also called Gresham College, where you will find thousands of outstanding lectures from people in every subject, from philosophy through to divinity, artificial intelligence to astronomy, as well as a bit of medicine. And if you sign up to the YouTube channel, I will be very popular when I go back. Thank you very much for having me.
I'm going to have to say something, aren't I, really? Obviously, coming from Great Ormond Street, I work with Martin. In fact, actually looking up before this, I did his last ever bypass before he retired from cardiac surgery. So it's a pleasure to have you here, not only as a mentor and a friend, but as an excellent speaker. As somebody's just pointed out on the live chat, they've put you down as the best presentation so far. So thank you very much for that.
Thank you.
I will admit to a slight disclosure or conflict of interest. My brother was actually one of the children that Wishart had in Bristol. Thankfully, he didn't die. He's still with us, still a pain in the ass. But he was one of those children that actually could have been caught up in this. And a further disclosure was actually I was parachuted into Oxford before it closed to try and sort out the perfusion side of things. So there's a little bit of a link there. So this is a sort of subject very close to my heart for what are we doing. I'm sorry for the pun. I suppose the question really is, can we pick up what you've said and apply it to a country where the model is very, very different? I know we mentioned, obviously, everything is sort of free in terms of we pay national insurance and that funds it from the government, but we don't pay at the point of going into the hospital. In a system where that is the model, how could we take what you've talked about, regionalisation, and move it into this country?
Well, unsurprisingly, it's been a topic of debate amongst cardiac surgeons on both sides of the Atlantic and in several parts of Europe for the last 20 years. You've got a very large country, so regionalisation on the scale that I've done is possibly not doable. But there are some themes that I think are instantly transferable. One is that you need to compulsorily collect the same data, and it should be transparent. It's very difficult from those people running organizations to duck the truth if the truth is visible. And if you can demonstrate that there is no significant difference between hospital X and hospital A, by having pooled data, they have to find a really good reason to chuck you out. So I think for me, there is power in groups of people like this getting together and kind of ignoring the system around them, because that's how this worked. We did this as cardiac surgeons in Europe, particularly in Britain, really starting in 1990. I started something called the European Congenital Heart Defects Database before there were networks, which was a stupid thing to do. And we collected all the data, and we did it very badly. But now we've got millions of patients from Europe on the data, and it shares a lot of structure with the STS registry, but not quite the coding. Our coding is more sophisticated. And the truth will dictate the way it's done. And you are in control of that as a group of people who influence things inside hospitals. it takes time. How long does it take? 1991 until now to get to this stage. But it was done in a bar, after a meeting like this. The best ideas were happening over a very large Bloody Mary, probably. And it drove everyone to be transparent. And I think that's the one word I'd leave you with, is transparency, because then nobody can argue with what you're telling them.
Just to follow up exactly what you've just said, it's interesting. So there's been a number of conversations. I'm going to point at certain people, such as Jim Rieger over in the corner there and Rob Baker. We've been having this conversation about how can we improve those databases, because if you look at any STS registry or anything else, the only part of bypass that is put in is the bypass time and the cross-clamp time. And unsurprisingly, it tells you absolutely nothing.
No, you need to tell them what variables are important, right? That's the first thing. And then test it. You run a collection where the data are peer-reviewed. I mean, the audit bit I sort of skimmed over, but every year the thought police come and check that your data are correct. They do. They look through, they match the paper records, if they exist, with the electronic records, and they look for anomalies. And anomaly is usually in weight, right? So it's simple things, the weight is always wrong. Blood pressure is always wrong. Those kind of things. And when you correct them, often the results get better. So, when you start to see change to the data being helped by audit, you suddenly get trust, and trust is the reason that we are believed by our patients.
Martin, great talk. Just a quick question about the national health system with regards to the money factor. Okay. Related to the money factor.
Oh, yeah.
Okay. So was there a lot of pushback when closing these centers, where the financial fallout would be with not doing those procedures in those cases?
No, they weren't not done. They were done somewhere else.
Correct. So the national health system still gained that revenue to a certain extent. So it wasn't the power of money.
No,
where in the United States, there's a big power of money.
Yeah, sure. Right? And, I've been in centers in the States where the only two payers are pediatric cardiac surgery and oncology. Right. So, the insurance companies pay those really without too much fight. So everybody has to have a pediatric cardiac surgeon. Right. When I was a hospital manager, I had the pleasure of being on the hospital management circuit. Sure. And the cultural shock of discovering that you hire these people because you can make money from it was very weird. Whereas we were always the high-cost center in the hospital, so it was kind of a different way of looking at it. Sure. The money shouldn't matter anyway, because what you're after is quality.
Absolutely, yeah. It's very interesting to see there are portions of our country that have multiple centers. Since we're in the state of Florida, that's one of them.
Yeah, and it has you saw the picture. I mean, this is a recurrent problem in Florida. And it's always going to be a problem when you have one surgeon or two surgeons not doing very much. It's always going to be a problem.
Yeah, very interesting. Thank you.
Thanks, Rob Baker. That was a fantastic presentation, Martin. I've heard the Bristol story presented before, but never with the depth and clarity that you presented it today. I just want you to address the issue of transparency and public reporting in terms of, the UK system of reporting down to the level of the surgeon is unique. And, I'm from Australia, we have great difficulty getting that as a concept adopted by our cardiac surgical group. I wonder if you'd like to speak to us about how you push for that public reporting, that transparency. And, I believe it should be down to, the level of the perfusionist. That sort of, at least within our peers, it should be at that level.
So it's getting increasingly easy because we're more confident that we're all good, right? So, when everybody's in that sort of confidence interval, you're starting to look at different, more specific elements of performance. And I'll talk a little bit tomorrow about Mark Delaval's analysis of surgical failure, just self-analysis. But an awful lot of performance monitoring of surgeons should be done in the team. And we use, I don't know if anybody knows about Q-sum charts. Do you? Yeah, so putting things on a Q-sum chart, which I haven't got a slide of, sadly, would be, so on the left-hand axis, you have failure rate, so that might be death or bleeding, return to theatre. And on the horizontal axis, you have case number, not time. And you suddenly see that you have a cluster of patients who are bleeding or going back to theatre. And conversely, you may have a period of time where none of them go back to theatre. They both deserve root cause analysis. So why are we winning and why are we losing? And you somehow neutralize some of that criticism because everybody goes through clusters, and clusters can occur randomly as a statistical variable. So it needn't be a bad thing. But the fact that you can put them up as an easy graph for everybody in the room to say, and very often a nurse at the back will say, that doesn't look good. And there's this sort of communal feeling that you're all working together for something better. Building that into your team by transparency within the team means that they're more comfortable with announcing their own results. On the other hand, the public wanted to know the center's results. And if there was anything dodgy, we want to go through it. So electronically, you can dig into it. Public are, remarkably able to work their iPhones, we found. And they go deep into these data if they want to. But mostly they're happy with this because they look at it and say, it looks pretty safe to me. On the other, I didn't say there is some specialization. So I did all the neonatal and infant tracheal reconstructions in the country because there weren't many of them and it made sense to do them in one place. So we do, between ourselves, agree that some stuff gets done in different places. But that's because we can talk to each other now without strangling each other, which happened quite a lot in the old days. Does that answer your question?
I have a question. You can see at the meeting here, we have a very large variety of equipment, from heart-lung machines to testing devices for bleeding issues and things like that, different cardioplegia types and techniques. In the UK, do you standardize some of that?
Well, I'm sure Richard would be better able to answer that than I, but there's a lot of conversation about it, but no, I don't think it is very standardized. I mean, we have less ability to buy the new thing on the shelf. So but there's quite a lot of budgetary constraints about what you buy. So we're not so much influenced, I'm sorry to say to the exhibitors, by what's available as what we can afford. Okay. And some of the changes we need to make have to be evidence-based, and you have to put in a business case in order to buy something, and that really forces you to look at the evidence, sometimes inappropriately, and because they don't want to spend the money. But looking at the evidence is really good, and if the evidence doesn't exist, you can't make the change. It's quite simple.
Okay.
I'll also answer your question. Is no, in a certain extent. We do have, at a national level, because there's only 420 perfusionists in the UK, so we all know each other. So there is a lot of standardization along practice, because of course it's a small group, it's easier to do. We're not got the sort of, is it 4,000 that you've got in the US? Yeah, so that's obviously going to be a bit more difficult. I would also add to Martin's comment about about cost, but also the fact that when you gather the evidence to do your business case, when there's no evidence there, you got to actually believe it. And I think the benefit of doing it this way is actually when you look at these things and you go through it and say, well, I want this because I think it's doing something, and you go through, you get the evidence, and you actually show it doesn't. And at that point, rather than just keep going, it kind of forces you to turn around and say, well, actually, there isn't any evidence, so therefore we're not going to go down that route. Or if there isn't any evidence, does that mean it's an absence of evidence or an evidence of absence? So you can work out and say, well, let's have a look at it in more detail. Let's do something that's going to then show us whether or not that is real. And then you've got something that you can then build on in the future. But a great example, I mean, Great Ormond Street itself is a relatively wealthy, in inverted commas, hospital, comparatively. And yet we have just bought some heart-lung machines, and we've chosen it because we could either buy 3 of one manufacturer's or 2 of the other. So that comes into play as well. So, even in a bigger centre, that still plays a massive part of what we're doing.
Thank you. I think you've... One more question? Yeah.
I just have one more question. And this comes to our health system's a mess, and advertising takes a big role here. So I can leave my house, and in the town I live in, go across the river, and at the end of the bridge, there's a billboard that says best cardiac surgeons, right? Before I get to the city, there might be 2 or 3 more. There's 2 huge giants in the city I live in. When I get to the airport, every single door to the tram and up the escalator is advertisements for the same 2 hospitals, or 1 hospital maybe that time. You get on the plane and you open any of the magazines that's in there. And that's true for the hospitals in that city. Millions of dollars are spent in advertising, and they literally can put up a billboard that says, best cardiac surgeon, best cardiologist in the world, without any transparent evidence. Do you see any of that? Or can I, if I were living in the UK and I know that you're the best cardiac surgeon for adult surgery and I want to come to your center, can I go to that center, or are you limited to where you can go, like our insurance just do for
So
us?
first of all, you'd have to prove that.
Okay.
But there's no, everyone's entitled to a second opinion, and everybody is entitled to move from one place to another. So there's no problem. It's a process. It takes a little time, but you can get it done. And the advertising is quite hard for me to see, especially when I got off a plane in LA and there was a big poster just at the end of the runway which said Vaughan Starnes, surgeon to the stars. And he'd been my registrar, so I was kind of really angry again. It's like getting a knighthood, you know. It's not acceptable. And that is a shock. And it's like, but it's equally a shock. You know, I have psoriasis and psoriatic arthropathy years ago, and I'm on some biologic. But it's a real shock to me. I've been here 2 days, and I've seen 5 different biologics advertised on the TV in just a few moments, all of which have appallingly toxic side effects. But the people have no psoriasis, of course, on the pictures, and their arthropathy isn't bad, you know. And you have to go and ask your doctor for this ridiculously expensive drug. So there is a problem with advertising and the way that market works, which I wouldn't criticize because it's the way your country works. But it's quite a shock when you come from a country which has a much more policed system.
Well, thank you. I really enjoyed your talk.
Thank you. Right, I'll disconnect. Yeah.